Thank everyone. Stephen Wang. My Chinese name is Wang Zhiyuan. Today I will explore a critical topic: how to manage the patient with a cardiorenal metabolic condition in their early stage. This interconnected condition will require the multidisciplinary approach, and I will share the insight based on the research in clinical practice in Taiwan. And as we know that the cardiorenal disease together with diabetes is a big burden for all over the world. When you look at the slide, you can see the left part, the prevalence of chronic kidney disease of type 2 diabetes in Taiwan is around 18%. And we have launched some study to investigate chronic kidney disease progression in type 2 diabetes in Taiwan. But most important one we found, patients never undergone urine protein testing, more than 40% in the past 20 years in Taiwan. So that is very pivotal message to send all the general practitioners and the medical center workers about to compare the transition rate toward advanced chronic kidney disease based on the nephropathy criteria, especially focus on microbinuria and the EGFR. And here it is, we ever attend the study in the CBD Real 3 before with Professor Lin Fangru and Professor here's Pink, Netherlands, that we found that all the patients in this study and all the patients in this study in Taiwan enrolled have the fair control for the glycemic control, and the EGFR is not so bad. But it is interesting for us to found in 5 different countries, including Japan, Taiwan, Israel, the United Kingdom, and Italy, has different results. Although we have the final result with statistical analysis as significant for the composite endpoint for reduction ESRD and end-stage renal disease, but there's still a puzzle for Taiwan why we have not really statistical significant change for the ESRD and the composite endpoint for 50% reduction. That is the previous we have index medication in this study. You could found in the old glucose-lowering agent, including metformin, sulfonylurea, DPP-4 inhibitor, TZD, and the GLP-1 has enrolled. The same is compared with the total with SGLT inhibitor, including dapagliflozin, EMPA, Cana, Ipra, Luzio, and tofagliflozin. We found the same result with the study. You could find the EGFR dipping in the initial first 3 months and recover 3 months later after the SGLT2 intervention. But it is interesting for us is, although in Taiwan we have the same trend for the study, but statistically not significant in that period. But from the previous UK PDA study, you had found a 5 years cumulative instance of proteinuria before. That is microbinuria and elevated plasma renal activity or renal replacement that will be occur together, especially for the patient with microbinuria. That will increase the evidence and increase the instance for the plasma renal activity elevation and even for renal replacement therapy. Together with such evidence, you could find that the microbinuria will be correlated with the mortality. That is a 5 year accumulating and about 20 years ago data. So in Taiwan, in the recent 5 years, we have tried to find a way of nephropathy development in type 2 diabetes and what is the risk factor for the study. So we launched a study of Taiwan P4P data analysis. What is P4P? This is the pay for performance. That is a very important regulation in Taiwan insurance regulation, and to pay the money for the general practitioner and diabetes educator to search for the definite parameters for the patient. So this is a retrospective observation study utilizing the real-world study result from Taiwan, and this is Taiwan National Health Insurance Research Database, NHRID. Enrolled criteria is more than 18 years old with type 2 diabetes, and we have recorded the medical record very clearly. And excluding criteria, including to exclude malignancy without information or the gender, and in the baseline extreme for serum creatinine or the baseline nephrotic syndrome acute nephritis, we were excluded. And the study we have reported in the 2023 IDF, we found that the primary composite outcome, together with the microbinuria analysis, and a 5 year instance for the EGFR change. And we also search for the secondary outcome, the risk factor for all cause of mortality with each EGFR category, including age and gender and history for heart failure. Actually, we found the age and the heart failure history is a very important 2 risk factors for the development for nephropathy. The characteristics for the study cohort, we enrolled 700,000 type 2 diabetic patients, and the gender generally even, and the comorbidity generally just like the real world. And you could find the mean age is older, about 60 years old, and the body mass index around 27, and the blood pressure with A1C is just a fair control. Especially for the serum creatinine and EGFR is not so bad. But we found a very important pivotal and even some horrible risk for that. The risk for mortality can surpass the risk for further kidney dysfunction, particularly among the patient with the EGFR around about 30 to 44, that is the stage 3B patient. When you look at the slide, you can find a 5 year accumulated instance for EGFR progression. Here it is the EGFR around the stage 4, stage 3B, and the 3B patient can progress to dialysis about 4.8%. But actually, around the 30% patient will cut mortality in this stage. If the patient progresses to the dialysis, you can find more, even higher mortality, around the 60%. So it is very important to find the patient earlier. 5 years accumulated data instance for UACR together with UPCR will give more evidence for us. Why we can have some conclusion for this? Because we found that in the past 20 years, around 40% of type 2 diabetic patient has not detected the proteinuria and the microproteinuria until the recent 5 years. So before, we found 5 years cumulative data for proteinuria. You could find progress from normal albuminuria to dialysis around 5 years. And around the microproteinuria is closely correlated with mortality. It is a very important evidence to show we must detect the proteinuria and the microproteinuria earlier. So the major finding for the TWPDS showed it is the first large-scale study in Taiwan to comprehensively investigate the progression of type 2 diabetes and with diabetic kidney disease over 5 years period. And compare the patient with eGFR around the 3B, 30 to 44 eGFR. Those with microproteinuria has nearly 3 times likelihood of progressing to the state of dialysis in 5 years. And albuminuria often precede the decline in eGFR in these Taiwanese type 2 diabetic data bank, indicating the potential as an early indicator for chronic kidney disease. Incorporating routine albuminuria screening in clinical practice could enhance the early detection for the chronic kidney disease and the management, leading to the improved their outcome and even though their quality of life. So secondly, I will show you data in Taiwan to show you the data why we should find the patient with type 2 diabetes and heart failure the earlier the better. This is a data multi-center collaboration with National Taiwan University, Majie Memorial Hospital, and the Far Eastern Memorial Hospital. We enrolled around 1,000 patients, and we collect the data around the 6,000 more patient study participants, and the average mean age is around 62 years old, to try to find a clinical utilization for the proBNP, the natriuretic peptide, on the basis of WATCH-DM score for heart failure prediction. This is the very first large-scale Asian diabetic study in Taiwan. But we use the WATCH-DM score for 5-year heart failure instance. You could find if we can carry out an EKG initially, and then we collect the data with the age, body mass index, blood pressure, and the serum creatinine, we can calculate the risk factor for the heart failure risk, and even to find a 5 years heart failure risk. And in this study, we stepwise the backward multivariate logistic regression, and we show that the instant heart failure event could be predicted earlier if we add on further parameter for anti-proBNP. Actually, even for the independent for the EKG and the history from cardiac function, atrial fibrillation rhythm, we can find that anti-proBNP is a very good indicator to find the patient with heart failure earlier. On the other hand, we use Kaplan-Meier score and to try to find the survival diverse outcome. And we use the anti-proBNP to find the cutoff around the 77 picogram per ml. It's very low in comparison with the real world 125 or 300 picogram per ml as the criteria heart failure. It is very low, but we show the data in type 2 diabetic patient use this cutoff, not only for heart failure, but also for heart failure with mortality together or with mortality we found it is different. And the risk increased more than 2 times, and even for heart failure death in 2.3 times in the hazard ratio. So in this period, we also enrolled the patient with 943 heart failure events, and 800 more had trackable left ventricle ejection fraction or heart failure phenotype classification. In this slide, you could find the heart failure phenotype. More of the patient is belong to the heart path that preserve the ejection fraction. That means we cannot find the patient earlier if we cannot carry out the ultrasound or other parameters. So it is very important to use parameters to find the patient with heart failure and diabetes earlier. So let me show you the case of, I will raise 2 cases. The case 1 is about the 58 years old female, and she has a diabetes history for 10 years, and not so high and not so heavy body weight. The body mass index is even more than 35, and if you want to adjust the body weight is 64, but actually she's 89. The medical history in the current condition is diabetes with poor glycemic control before despite regular medication, and hypertension, anti-hypertensive medication, and hyperlipidemia also on statin therapy. Here is the glycemic control in the past few days and a few years. You could find the serial A1C data from 2018 to 2024 every 3 months. The initial range for from the March 2018 to 2020, the HbA1c fluctuated between about 6.2 to 7.5. Not so bad, but relatively better control before. But in the middle range, in the pandemics, you know that in pandemic, many patients with poor glycemic control. This patient is not exception. So the A1C increase more fluctuation ranging from 7.2 to 9.4, indicating worsening control. In the recent 1 year, 2 year, the A1C remained variable between 7.2 to 9.3, suggests persistent suboptimal control. But in this period, we use medication with antihypertensive medication and olmesartan 40 mg once daily, and the mebalazine 30 mg once daily. And we use crestor, rosuvastatin 10 mg once daily. And now the diabetes medication is glycine, that is the linagliptin 5 mg with empagliflozin 25 once daily, with metformin 500 mg twice daily, with glimepiride 2 mg twice daily. You may ask me why the patient will not intervene with insulin. Actually, the patient refused to receive injection therapy, especially insulin, because high body mass index. You know that insulin will increase body weight even for sometimes for edema, and the patient is needle phobia patient. But actually, we found that the patient proteinuria. So in early stage of 2018, we found microproteinuria a little bit. So we add on SGLT2. Actually, we add on SGLT2 inhibitor is not for the microproteinuria, but for the glycemic control. But 1 year later, and from the 2019 to now, you could find the proteinuria, microproteinuria improved very much. When you look at the curve, you can find initial microproteinuria after intervention for SGLT2 inhibitor, the proteinuria, microproteinuria improved very much. 1 year later, it can maintain with normal albuminuria. So the clinical note for this patient is important. The high body mass index is a very important part that suggests obesity and contributed to the improved glycemic control and complicated management of hypertension and hyperlipidemia. Especially for the A1C, you know that the patient is significant fluctuation for A1C, particularly in the last 2 years after pandemics, indicating consistent diabetes control, no matter diet control, exercise. So the better control is very important, especially in contrast with the poor control more than 9%. The current diabetic method was a combination of targeting multiple pathways, the SGLT2 inhibitor, DPP4 inhibitor, insulin sensitizer, or even through insulin secretagogue. Despite this recent A1C suggests that the patient needed more optimization, we will intervention, the GLP-1 receptor agonist insulin if the patient agree. But the last one is most important. You want to evaluate patient with type 2 diabetes and with early stage, what is the evidence? That is microproteinuria. The previous given the history of hypertension, hyperlipidemia, diabetes, obesity, and cardiovascular could be based on the finding of microproteinuria. Maybe we cannot use the concept that if you decrease microproteinuria, it can decrease the cardiovascular risk. But you could still say if you decrease microproteinuria, you could decrease the risk for chronic kidney disease. Here is the case 2. Case 2 is Mr. Zhang, a 65 years old male, and the body mass index is 27 around. The diabetes history for more than 10 years, and the diagnosis for type 2 diabetes, A1C is not so bad, it's around about 68 to 7.5. The fasting blood glucose is around 110 to 130 milligram per deciliter. So actually, the fasting glucose is optimal control according to the regulation of American Diabetes Association. But the heart is so bad because the patient found the heart value will reduce the ejection fraction from the cardiac echo. The left ventricular ejection fraction is only 37.5%. They classify the HAAC as stage 2 heart failure. Especially the patient got the history for acute coronary syndrome with a minor stroke 2 years ago. That means the patient is a very high risk group for ASCVD. So let's review the clinical history and medical condition. The patient is a 65 years old man, type 2 diabetes, diagnosed for many years, and the heart failure with left ventricular ejection fraction is 37.5. That is the half ref. Half ref that means the patient maybe with a higher risk in comparison with normal people. According to the previous study, we know that the mortality for half ref and half ref is equal, but actually the half ref is more even serious. The occasional dyspnea exertion could be found, but there's no nocturnal dyspnea. And the edema for lower leg was found to suggest fluid retention due to heart failure. And finally, the history for acute coronary syndrome 2 years ago followed a minor stroke. That is a very important condition now. So let's review the lab data. We could find the proBNP is 680 p1 per ml. It's elevated, suggested for heart failure. But actually, if we review the patient body mass index, his body mass index is around about 27. In comparison, the case 1 lady, the body mass index is 35. You could find the proBNP is more reliable. Because the patient got a fatter and obesity, the proBNP was even lower in comparison to real heart failure. On the other hand, the creatinine for this patient is 1.6 milligram per deciliter, mild kidney impairment possibly due to diabetes or heart failure. But there's no data for ACI. It's a pity for us because we review the patient followed in the cardiovascular department and the metabolic department together, but no one to check microproteinuria. So that is the one why we focus. We need to check microproteinuria regularly as early as the better. The fasting glucose is is around 130. There's optimal fasting glucose. A1C is 6.52 and 75. The goal reached, but closer to high end, a little bit fluctuating. And let's review the medication. First of all, the patient is a patient with a heart ref. Half ref receives Entresto. From the study of parity, look at the sabicutril together with the Foxartan twice daily could improve the patient for half ref. And we add on the empagliflozin together with glycemic control and heart failure control. And we use 10 milligram once daily, follow the EMPA kidney and the EMPA half ref, EMPA reduced data. In diuretics, like furosemide 40 milligram daily, and we will adjust for the fluid retention, and we could adjust the dose as the patient condition change. And finally, we have semaglutide, the Ozempic 0.5 milligram once daily for diabetes management and weight loss, especially for the patient is a patient with a stroke and priorly for acute coronary syndrome. Metformin is a regular medication, and now we intervene the glargine intervention for 18 units of QTNs at night. So in comparison, case 1, you could find the patient is more cooperative with us. He can take more medication, and the patient will be more safe. And actually, for clinical notes for the patient, the heart failure management for such a type 2 diabetes, we will continue for the Entresto, the sabicutril with Foxartan twice daily, and we will increase the diuretics as necessary to manage edema. But the current dose for 40 milligram per daily may be increased or decreased based on the body weight and fluid status. And finally, we could find the renal condition is a very important one. Adjust diuretics and adjust for Entresto is an important parameter. And we monitor the body weight and edema and regularly assess the fluid condition and adjust treatment accordingly. And the clinical two is a very important one. We will continue for SGLT2 inhibitors for empagliflozin, 10 milligram daily, for its dual effect for managing heart failure and improved glycemic control. Continuous metformin and continuous GLP-1 will be better for the heart condition. As you know, the UKPDS, metformin is the only one for the older paradigm to improve the cardiovascular mortality. And in the future, semaglutide is another one for the cardiovascular and the stroke risk. And finally, we will adjust the insulin, 18 units at night for the glycogen, based on the blood glucose control, possibly increasing dose if the fasting glucose will be even higher. So when we look about the two cases of the patient, we could found the cardiovascular, renal, and metabolic condition frequently coexisted because they are interrelated. So if you look at the slide, you can find that every panel here, up to 60% of people with chronic kidney disease having heart disease. And you could find in the lower panel, 20 to 40% of people with heart failure with type 2 diabetes. And you could find approximately 1 in 3 patients with type 2 diabetes with heart disease. That means the CKM, cardiovascular, kidney, and the diabetes, they were intercorrelated very seriously. And here it is, the heart failure for kidney condition declined would interact together, and the complication with one often exacerbate each others. When you look at the left panel, you could find the heart failure is associated with a high risk of instance for chronic heart disease. So you look at the panel here, with heart failure with even higher instance for kidney disease together with heart failure. And in the right panel, you could find the instance for the heart failure in the higher in the chronic kidney disease with heart ref and heart PAP together. That means for the patient with chronic heart disease, no matter heart ref or heart PAP, it is a high risk group. So the coexistence for type 2 diabetes and kidney disease is associated with increased mortality is not important pivotal issue. If we review the enhanced study from the United States population-based data, you could find the type 2 diabetes with eGFR lower or type 2 diabetes with albuminuria and eGFR lower than 60 has a higher excess mortality. In comparison, there's no type 2 diabetes or no kidney disease. So it is very important to emphasize, if we cannot find the disease earlier, we will miss the opportunity to prevent the progress of this disease, no matter the glycemic control, no matter the chronic kidney disease change, albuminuria, no matter the heart failure change, or even the mortality. The updated guideline highlight the importance of comorbidity and mortality and recommended SGLT2 such as Jardiance as the most important medication in the future. From the viewpoint of diabetes in ADA, it is first line depend on the comorbidity. From the heart failure, H and ACC guideline, the individual therapy for heart failure and comorbidity, including type 2 diabetes. As you know, type 2 diabetes is not only disease for glucose control, but a very important disease and a high risk for the mortality. The recommendation provided for selected patients with heart failure and iron deficiency, anemia, blah, blah, such patients is very important. But you know that for the patient with heart failure, now SGLT2 is not used only type 2 diabetes, but for non-diabetes. On the other hand, of chronic disease, we have KDIGO data, comprehensive care for the patient with diabetes and chronic kidney disease. So in the chapter 1, if you review the comprehensive care for patients with diabetes with kidney disease, they will tell you patients with diabetes and CKD should be treated with comprehensive strategy, reduce risk for kidney disease progression and the cardiovascular disease progression together. That means SGLT2 is a very important and the pivotal reason. So if we review the data, except for the GLP-1 receptor antagonist agonist in the recent data, the SGLT2 is a very important paradigm to use to prevent chronic kidney disease and heart failure. The guideline recommended for use SGLT2 inhibitor such Jardiance across the cardiovascular, renal, and metabolic condition. So if we review 2022 KDIGO, 2022 ADA together with coded consensus, or the ADA 2023, or the ADA ESD 2022, the SGLT2 inhibitors are recommended as a first-line therapy for patients with type 2 diabetes and chronic kidney disease. So that means SGLT2 is a very important part in the future for the cardiovascular and kidney disease in type 2 diabetic patient. So if we care the patient, if not care the disease, we care the body, care the human being. So holistic approach is very important for chronic kidney disease and the heart failure. So in 2024, we will review the KDIGO. You could find the chronic kidney treatment and risk multiplication must be used the basis for the holistic approach. If you review the lifestyle, you can take more healthy diet, physical activity, and stop use of tobacco and the weight control. But SGLT2 will be the first line medication to prevent the dialysis and prevent the chronic kidney progression. So recommendation for the SGLT2 inhibitor will expand to the chronic kidney disease independent of comorbidity. That means if we use the medication as secondary prevention, that's okay. But now it may be used to be the primary prevention for the kidney disease in the early stage. So finally, I will give some take-home message from my viewpoint. The prevention and treatment of complication is very important, but not so easy, because increasing number of diabetic patients and the longer duration for illness is the very important challenge in the future for 21st century in the next 30 years. So prevention and the treatment for diabetes-related complication is a very important one, not only for the physical, but also for the major public health issue. That early detection, effective treatment, good control for the glycemic control and the blood pressure and the blood lipid are crucial to slowing the progression of diabetes and its complications. And secondly, significant improvement for the care. It means multinational survey and a multidisciplinary care for such patients. If we review previous data, we could find for years that show significant continued improvement diabetes all over the world. If you want to care the patient better and we can prevent the complication earlier, particularly in the diligence and achievement rates of the important treatment goal for A1C, blood pressure, and lipid. This improvement will help patients to raise the quality of care of the patient. So, ladies and gentlemen, you want to review the patient with a different type. We must use the medication as early as possible because maybe you cannot change the patient behavior very easily, but you can keep the adherence of medication very easily for the patient. So here is my report for you, and thanks for listening. Thank you.
So thank you so much for the invitation, and it's my great honor here to be able to share with you just a few cases. So Professor Wang, gave a very elegant talk just now about how we need to detect and initiate early SGLT2 inhibitors for people, catch them before it's too late. And for my talk, I would like to share with you a few cases of focusing on more advanced CKD. So I always, put this analogy of this, what I call the CKD stage 3B to 4 cliff, which is exactly what Professor Wang just now was referring to. So once you hit that kind of advanced CKD stage, people rapidly, drop off, either both in terms of the renal function. So, they either develop one of the many complications, which include, obviously developing ESKD, but also developing heart failure, MI, and other stroke. And actually, we looked at our own data in Hong Kong, and very similar to what the Taiwan experience. So actually about 30% of people actually also die. So I mean, I think, my job is mainly, working in sort of internal medicine and diabetes endocrinology. So I'm here mainly for trying to optimize all the multiple risk factor control, optimizing RAS therapy. But I think now, we have in the last, maybe 5 years or so, we've been very lucky in that there have been sort of a lot of newer medications that can potentially, still effective at this kind of stage, that can potentially sort of fend off some of these, serious complications. And these include MRAs, GLP-1 receptor agonists, and of course, SGLT2 inhibitors. And I'd just like to share with you 2 cases I saw recently, and thinking about what are the considerations of starting SGLT2 inhibitors in people with diabetes and more advanced CKD. Okay. So this is his first case, is Mr. Y. I think I also spoke at another conference in Taiwan a few years back, and we all know that young onset diabetes is a huge problem in Asia and also in Hong Kong. So this is a very young man. So he's only 44. He works as a salesperson. He's a non-drinker, non-smoker. He was diagnosed with type 2 diabetes, diabetes aged very young. So he was only 15 at that time. He was had morbid obesity since childhood, and he had a left nephrectomy in childhood for some unknown reason in mainland China. So at that time when he first presented, it was documented that his glucose was 52.8, his pH was 7.35 with 3+ ketones, and he had reported a week's history of polydipsia and weight loss. So, but somehow this was labeled as DKA. He was first started on insulin, but eventually actually he was able to tell it off for a short period a few years later. However, actually on presentation, he already had about 0.5 grams a day of proteinuria, and at that time his EGF was 56. He was started on ramipril back then. In terms of family history, his mother has type 2 diabetes, age 65, but just on oral agents. So this was him maybe just a few years back. So this is in May 2021. So at that time, his blood pressure was 132/72. His weight was 92.3 kilos. His BMI is 34, so still very, very overweight for what it should be. At that time, his EGFR was already only 27 with a creatinine of 277. Urine ACR we did measure, so it was 28 milligram per millimole. His potassium was 4.9, LDL cholesterol 2.1. His HbA1c was about 7.8%. So at the age of 44, he's already in the the G4A2 very, very high risk end already. So at that time, his medications included allopurinol for gout, losartan, 100 milligram daily. So he was on sort of pretty maximal RAS therapy. He was already on MDI insulin. So he was on insulin glargine 20 units at night, and then aspart 7 units pre-breakfast, 8 units pre-lunch, and 7 units pre-dinner. So he was also on atorvastatin 20 milligrams daily and amlodipine 10 milligrams daily. At that point, actually, he's reasonably well. He denies any shortness of breath. He denies any lower limb edema. So, I mean, I think this is just a reminder about this is the ESD-ADA consensus, which, as we'll be talking about, advocating a sort of a holistic person-centered approach to type 2 diabetes management. And, moving on from how our traditional approaches has been. So now we do think about 4 key components as carrying equal weight. And one, of course, very important thing is thinking about cardiorenal protection and using drugs such as SGLT2 inhibitors or other, drugs with proven organ protective therapies, which are, independent of the glycemic control. But at the same time, the other pillars are also extremely important, including thinking about the glycemic management, the weight management, and not forgetting our simple things, the overall multifactorial cardiovascular risk factor management. So that includes, your lipid lowering, anti-thrombotic agents, and also smoking cessation. So the first thing I was thinking about, so obviously, what should we do in this very high-risk young gentleman? So thinking, what can we do in terms of cardiorenal protection? So I mean, I could open this to the floor and to our fellow experts. So what would you do next? So would you start an SGLT2 inhibitor, GLP-1 receptor agonists, or both, or together? Okay, so I'll tell you what we did. Okay, so actually, at that point in the clinic, so actually, we obviously he would probably benefit from a GLP-1 receptor agonist. He was probably benefit in terms of weight. His glucose control would probably benefit because of the GLP-1 also has some enhancing the insulin secretion, and obviously, importantly, the GLP-1 receptor agonist will probably confer some cardiorenal protection and probably ameliorating some of the albuminuria and EGFR decline. So we started the dulaglutide 1.5 milligram once weekly subcutaneous, so in our clinic we do sort of jointly started with our diabetes nurses. So usually we tend to review them within the first 2 to 4 weeks. We warn them about potential GI side effects, but fortunately he actually tolerated reasonably well. And sometimes it's a little bit maybe more difficult to manage in people already on maybe complex insulin regime. But fortunately, this gentleman already participated in one of my previous trials of CGM in people with advanced CKD. So he was already sort of using personal self-monitoring with CGM. So with that kind of guidance, we were able to start the GLP-1 with some minor fine titration to the his insulin doses. Actually, in terms of glucose control, it was reasonable. So he was getting time in range of about 69%. So time at the high was only about 23% and very high, about 8%. And he had no hypoglycemia. So next, I mean, I think about the SGLT2. I don't know if anyone would have any hesitation about starting the SGLT2 inhibitor in this gentleman who would probably obviously benefit. I think the sticking point sometimes is that we see this, diagnosis of DKA emerging somewhere in the history, but actually we sort of went back to the original clinical notes, although, it was a little bit difficult because it was very, very many years ago. But if you look at the pH, it was also maybe a little bit borderline, and I think it was not entirely very clear cut that this was just pure DKA. However, given the sort of the benefit of the doubt, so we did actually check the C-peptide and also some anti-GAD antibodies. So actually his C-peptide was sufficient, his anti-GAD was negative. So we felt comfortable to start him on SGLT2 inhibitor empagliflozin 10 milligrams per day daily. And of course, we educated on the sick day rules. So he was also continued to the insulin therapy, and he sort of continued to do fairly well. So this was him. So this was initially in May, before we started the SGLT2 or GLP-1, and then this is his more recent follow-up. So we could see he continued to do well. He lost a reasonable amount of weight, so about 5 kilos. His blood pressure is well maintained. His HbA1c also improved. It came down to about 7.1%. His LDL cholesterol also was optimized, and with some improvement. So importantly, it seems like at least his EGFR has been holding around maybe between 23 to 25. When we're not typically seeing that rapid decline, which hopefully really would mean we can stave him off dialysis for a little bit longer. But I think what was quite impressive was the decline in urine ACR. So I mean, I think in the past we've been we don't really see that his urine ACR actually really progressively decreased from like 28 down to 8.6. So this is still dropping. So I think this kind of shows that even in starting this in relatively advanced CKD, there are still benefits to putting people on the SGLT2 inhibitor. So this is some analysis done by some colleagues at the University of Hong Kong, Dr. David Loy. And so they were looking at sort of real-world data from about 2,500 SGLT2 inhibitor users versus GLP-1 receptor agonists users, and they were sort of propensity matched. So if you look at the pre-slope in terms of EGFR, so it was sort of minus 2.5 in SGLT2 inhibitor users versus minus 2.3 in the GLP-1 receptor agonist users. And after they initiated on these agents, I mean, there were sort of benefits in both groups, but perhaps with the SGLT2 inhibitor users, the decline was a little bit less, so minus 1.2 mil per min per year. So again, so this is actually a paper just published in Circulation done by Nguyen et al. So this was taking data from the various large RCTs like the Credence and the Fidelity trials, and they kind of estimated the treatment effects on the cardiovascular outcomes as well as CKD progression, all-cause mortality with SGLT2, GLP-1, and also NSMRA, either alone or in combination. I think if you just look at CKD progression, you could see that perhaps there's a slightly greater benefit for SGLT2 compared with GLP-1 receptor agonists. But if you use the two together, you could still see that you could reduce the risk by nearly 50%. And with plus the NSMRA, really the hazard ratio goes down to 0.42 in terms of CKD progression. And then similarly, if you look at all-cause mortality, you could see a very, very clear benefit, individually with each agent, but also additive benefits when you prescribe the two together. So the hazard ratio is like 0.75, so 25% reduction in all-cause mortality, which I think is still extremely important for protecting our range of patients with type 2 diabetes. So this is my second case. So this is Mr. L. So he is a 71-year-old man. He's a non-smoker, non-drinker. So he is actually still working as a daytime taxi driver. So he drives a taxi from 7 a.m. to 4 p.m. So he was diagnosed with type 2 diabetes in 2005. So he's had diabetes for nearly 29 years. So he had some suboptimal glycemic control. So his A1C was about 8.4% in 2018 when he was on maximum oral agents, and he was started on supplementary insulin in 2019. So his urine ACR was 9 milligrams per millimole at diagnosis, and he was started on low-dose ACE inhibitors all along. However, we already noted on his annual complication screening back in 2017 that his EGFR was only 40 with the urine ACR of 5.9 milligram per millimole, putting him in the G3B/A3 stage. He also has bilateral non-proliferative diabetic retinopathy. He's known to have hypertension, hyperlipidemia, and a history of atypical chest pain. And he had an echo done not too long ago which showed an LVEF of 65%. So this case, I actually only saw him last week in our diabetes clinic. So at the time, so his weight was 67 kilos. His BMI is 25. His blood pressure was 148/92. And he's been complaining of increasing lower limb edema to the mid-shin. However, no orthopnea or chest pain. He actually, he definitely thinks that he has very good medication adherence, denies any nephrotoxic medications, NSAIDs, etc. But so he has also been very diligent in performing home blood glucose monitoring, but this has significantly deteriorated. His metformin was stopped 6 months ago. So his pre-breakfast readings was ranging from 8.9 to 12. Even post-meal, post-lunch is going up to the 20s, even up to 23 post-dinner. So he actually was quite distressed at this point. So the medications that he was on, so he was on atenolol 25 milligrams daily, lodipine for his blood pressure. He was on sort of maximal RAS inhibitor, lisinopril 20 milligrams daily. He was on some glimepiride, atorvastatin 30 milligrams, alogliptin, DPP4 inhibitor, and then he was on prolofane, insulin, 16 units in the morning and 18 units in the evening. So this was his EGFR and urine ACR trend. So I mentioned that in 2017 we already know that his EGFR was about 40. So this is what happened. So you could see that since 2022, you could see his EGFR was starting to fall. So in a year ago, November 2023, it was already 34, and that further went down to 23 in June. And then when I saw him, it was only down to 20. So a very rapid decline. So we did monitor urine ACR at various points. So it was also extremely high. 429 milligram per millimole, extreme, very macrorenuric. So what about his HbA1c? Actually, previously all along he's been very well controlled with the A1c between 6.5 to 7%. But so in obviously a year ago, because his EGFR decreased, so his metformin dose was halved. So his A1c went from 7.4 to 9.5%. And last visit in June, because his EGFR now dropped to below 30, his metformin was stopped. And when I saw him, his HbA1c was 11.5%. So other investigations, so his hemoglobin was holding about 12. His LDL was probably still not in target, 3 millimoles. His serum K was actually okay, it was 3.7. Serum creatinine of 286, ALT of 17. He already had a renal ultrasound recently, which showed just bilateral parenchymal disease and some renal cysts. He also had a nephritic screen, excluding other secondary causes, and that was largely unremarkable. So I think, this was the first time I met him, and unfortunately he was already in the G4A3, and my feeling is that he is already sort of falling off the cliff. And it was, very sad because he was quite a, well-working gentleman. So, I think, just revisiting kind of the management approach. So again, for him, I think, we tackle all these things simultaneously. So one is the cardiorenal protection, secondly, glycemic management, and thirdly, obviously the CV risk factor management, which includes the cholesterol as well as the blood pressure. So first of all, I think the first thing to consider is for the drugs for the cardiorenal protection. So I did start him on an SGLT2 inhibitor. I started on empagliflozin 10 milligrams daily. So I know sometimes some of my other colleagues may be a little bit and about starting people in SGLT2 around about the 20 to 30 range. I'm not sure. Maybe sometimes they think, oh, okay, they worry about possibly AKI or some other sort of factors which will contribute to further decline. But for me, I think the evidence is clearly there that the SGLT2 inhibitors are still helpful even in advanced CKD. So this is work done by our colleague Professor Sito Gordon and Jack and Dr. Zhao Kaiming. So this was data from Hong Kong. So this was a retrospective cohort, propensity matched study comparing SGLT2 users versus non-users within the CKD stages 3B to 5 non-dialysis. So for this analysis, they compared about 1,400 SGLT2 users versus 4,000 matched, controls. And you could see, clearly that SGLT2 inhibitors use was associated with lower risk of kidney-related adverse events. So 7.7% versus 24% with an odds ratio of 0.47. You could see that this is true across people with EGFR below 30, but also EGFR below 20. And also in this analysis also very nicely showed that the benefits in terms of MACE. So here again, you see that those using SGLT2 had a low risk of MACE, 9.6 versus 15.1%. And then clearly the benefits were still present at lower EGFRs below 30 and 20. And of course, I think I've always been very impressed by this paper from Taiwan. So this was a very, very big cohort, looking at use of SGLT2 in type 2D with people with stage 5 CKD. So this was target trial emulation comparing, about 23,000 SGLT2 inhibitor users versus non-users. And you could see clearly that the risk of chronic dialysis, as well as a number of other, heart outcomes were reduced in those people who were treated with SGLT2 inhibitor, even in this very late stage of CKD. So the second thing, obviously, we couldn't forget is obviously addressing the glycemic management. We have sort of done a couple of analysis and papers on this issue. So this was a paper done by Apme Yang, who is one of our data scientists. And this was using the data from the Hong Kong Hospital Authority territory-wide. So we emulated a target trial. So we took about 33,000 metformin users and compared, what happened to them. So, about 22% discontinued metformin versus about 26,000 who continued metformin within 6 months of reaching EGFR below 30. And you could see that those who discontinued metformin who had about a 1.5 times higher risk of developing ESKD, and also the risk of MACE was higher, about the hazard was 1.4. But also you could see that the benefits of continuing metformin also apply for all-cause mortality, as well as the non-CB and non-cancer mortality, which was primarily related to protection from pneumonia. But this was other thing we can obviously, I'm sure a lot of clinicians have experienced this phenomenon, is the rapid deterioration in HbA1c upon discontinuing metformin. So see what we saw with this patient, you can see quite frequently within the first half a year, the HbA1c goes up, quite, a lot in our study about 1% after you discontinue the metformin. And although probably, once you up titrate the other medications such as insulin, it does come down. But because you have to increase the insulin as well as potentially other drugs, there is an increased risk of severe hypoglycemia. So in our data that we just looked at, amongst those who discontinued metformin, they had a higher hazard of severe hypoglycemia with the HR of 1.12. So for this gentleman, so obviously remember that starting SGLT2 would have very minimal effects on glucose lowering in these people with advanced CKD. So obviously I definitely intensified the insulin therapy. So I switched him from just twice daily protophane to 26 units pre-breakfast and then 8 units pre-dinner with the aim of up titration. But for him, it was a little bit tricky because obviously he was at high risk of hypoglycemia and he's still working as a daytime taxi driver, and he only takes a sandwich at lunchtime. But nevertheless, we also referred him to our diabetes nurses who sort of did a lot of education with him. The other thing sometimes that we are a little bit wary of starting SGLT2 inhibitors is in people who have very poor glycemic control, especially people who we were worried about they're not adequately insulinized because of the risk of DKA. And from the literature, it does seem that the risk of DKA is higher in type 2 diabetes amongst patients who are older and with longer disease duration. But nevertheless, I think, as long as we can educate the patient appropriately on the sick day rules, and this is a standard sheet we now give to all our patients starting SGLT2 inhibitor, and importantly, to ensure adequate insulinization. So do not reduce insulin, or in this case, obviously we had to up titrate it and educate the patient on sort of very close monitoring. So in this case, I think it's sort of generally safe. So finally, I think not to forget the importance of other CV risk factor management. So we did increase the atorvastatin dose and added ezetimibe to optimize the LDL cholesterol. But I think the fourth point is the most important. So we arranged very, very early follow-up and referred him to the renal team. So I think this is the hypothetical real life application if we project the findings of EPIC kidney trial to different trial subgroups. So as Professor White alluded to earlier, if we're starting someone on SGLT2 inhibitors, we are going to make a much bigger difference, and we'll be able to delay the time to KRT by 26 years. However, if you start someone with EGFR at 20, you can only make a difference for about 1.9 years. But nevertheless, I think having 1.9 years is doing something better than nothing. So I think, finally, from the moral of the story for me is, was it too little, too late? I think, we already knew about this patient being very high risk in this, advanced CKD with macrobinuria category, only 5 years ago. And I think the other thing is about the frequency of monitoring. So, and I think we should be monitoring both the EGFR and urine ACL, maybe 3 to 4 times a year, and definitely initiate timely referral. So thank you very much. So this is just some of my sharings, and I look forward to further discussion with all of you. Thank you.